case will be presented by Dr. Mithila, and I was told that this is a case of hematological disorder. So Dr. Raj Vardhan is also there. He will moderate the case. So Dr. Mithila, shall we start?
Yes, sir. Good evening, sir.
Are you ready?
Yes,
With your
sir.
slides?
Yes, sir.
Okay. I think we can start. Dr. Raj, if you want, you can ask her questions in between also. Okay. Is he there, Dr. Raj? He's muted. Can you unmute yourself, Dr. Raj?
Yes, sir.
Yeah.
Yes.
So I think we should start. People can join in between later also. Okay. We start
Yes.
with the case presentation. Right, Dr. Mithila, please.
Yeah. Good evening, everybody. Today we going to be discuss one hematological case. So there is a one female baby, 4 year old, resident of East Delhi, Punjabi by ethnicity, and the informant being mother. Child was known case of the hematological disorder and is on regular blood transfusion since at 1 year of age and currently presented for the same. Currently, there is no history of fever, cough, cold, vomiting, loose motion, feeding difficulty, or any yellowish discoloration or rashes. Uh, Going to the past history, child was apparently well until 8 months of age.
I can't hear. Can you speak a little louder, Dr. Mithila?
Yes, sir. Sure, sir. Am I audible, sir, now?
Yeah, slightly better.
I'll use headphones, sir.
Yes. Now it's better. How old is your patient?
4 years, sir.
Oh, good. Right.
Just second, I'll just join with it.
Hello?
Yes, sir. I'll continue.
Now, clearly audible. Yes. Can you make it full screen?
Sir.
Your presentation? Yes. No. It's good. Go to the previous one. Yes. Yeah. Start it.
So child is known case of hematological disorder and is on regular blood transfusion since at 1 years of age and currently presented for the same, and there is no history of fever, cough, cold right now, and no history of vomiting, loose motions, or any feeding difficulty or yellowish discoloration or any rashes presently.
So basically, you want to say that child has come to you basically for his routine blood transfusion, which he is periodically getting.
Yes, sir.
Okay. Next.
So the child was apparently well until 8 months of age, and parents noticed the pallor of the body along with child was not able to gain weight adequately.
Okay.
So At that time, there was no history of recurrent cough, cold, fever, or breathing difficulty, no history of easy fatigability, difficulty of breathing after physical activities or playing, no history of yellowish discoloration, chronic diarrhea, constipation, or GI bleed, no history of bony pain. There was no crying of baby was not crying while handling by parents, long duration of fever, night sweat, no history of dark color of urine, no history of pica, bleeding from any side, swarm infestations, or the exposure to the drug or toxins.
Okay. So you are saying child was apparently well till 8 months of age, and
Yes, sir.
parents noted pallor at this. What are the common 2-3 conditions which will present with pallor at that age, and child is okay immediately after birth for a few months? You are not examined the child, so it
Yes,
is just by the history.
yes, sir. By history, it may be some hematological conditions like thalassemia
Eh,
or aplastic
Yes.
anemia, or if there is a inherited bone marrow failure disorders like Diamond-Bachmann
Okay.
syndrome, then
Okay.
Schaumann-Diamond syndrome, sir.
Okay.
Or if there is just a temporary pallor, so it may be because of the worm infestations or the temporary
No,
loss from
you
any.
should, from this age, sometimes 8 months onward, those who are only milk fed and mother was deficient in iron, iron
Yeah, so
deficiency also comes
yes,
in
sir. Iron
at this
deficiency.
age. Because your child is otherwise normal looking. He doesn't have any
Yes,
other problem.
yes,
Cough,
sir.
cold, fever, breathing difficulty, loose motion. He doesn't have any other symptom. He is a playful, otherwise normal
Yes, sir.
looking child, except for pallor. That is the quality of thalassemia. That they look otherwise okay. They may present sometime with the some infective means condition which may precipitate it. And by the way, one thing you tell me, why doesn't thalassemia present at birth?
Uh, in thalassemia, there is either alpha or beta chain deficiency, and during birth, sir, there is a more fetal hemoglobin which contain alpha and delta chain. That's
Hmm.
why when the fetal hemoglobin start reducing after 6 to 8 months of age,
Yes,
then
the simple answer you have given correctly that see at birth majority of the hemoglobin is formed by fetal hemoglobin, and then there is a fetal switch off, means fetal hemoglobin production goes down and adult hemoglobin production goes up. So it takes few months for that this transition to occur. So till that time, so most majority of the children born are generally normal thalassemics at birth.
yes,
Okay,
sir.
they present generally after few months. If the variety of thalassemia is severe, they may present even at 2-3 months. Nowadays, with more awareness, people are detecting this condition earlier. We are getting patients at 3 months, 4 months. Earlier, we used to say that generally thalassemics present between 6 months to 1 year. But now, because of increased awareness among doctors, also the detection is earlier. Fine. Okay,
Yes,
we
sir.
go ahead. Next one.
Yes, sir. For the above mentioned complaint, parents consulted a local doctor and investigations were done. And as reported by the mother, she was diagnosed with a hematological disorder that require regular blood transfusion. There was no history of neonatal jaundice or no history of bone pain or deformities or no history of recurrent infection, easy bruisability at that time.
Yes, you have rightly written those in the bracket, those conditions. Why did you ask for neonatal
Yes, sir.
jaundice? In hereditary spherocytosis, what else will you find in the
Sir,
history and
gallstones. Yeah, gallstones, but it will be developed later in the life, or there is a history of gallstones in the
No, they may
parents
present with severe jaundice at birth,
at
that
birth.
you rightly written, and in that there will be a family history because it is a autosomal
Well, dominant.
dominant disorder.
Yes.
Though there will be a strong family history. One of
Yes.
the parents might be having history of jaundice or surgery for gallstones or all that.
Yes.
And similarly, bone pain or bone deformity in
Fanconi.
Fanconi's. Malignancy, one thing, it is rare at this age. And secondly, like in you're thinking of leukemia and other diseases, then they are you generally what happens? They are sick looking.
Sick looking and
There
failure to
is
thrive.
bruising and then they have bleeding and okay.
Yes, sir.
No history of recurrent infection and bruisability. Why, in which type of malignancy?
Sir, I mainly ask for aplastic anemia or bone marrow failure syndromes where there is a
Yes, bone marrow
pancytopenia.
failure syndromes are there, and some of them, like congenital dyserythropoietic anemia, some only one variety, three will present at this age, others will
Yeah.
present later in life.
Yes, sir.
Okay. What other things will you think of if a child presents to you with you not examined the child? Will you keep storage disorders,
Yeah. Yes, sir. Metabolic
congenital,
storage
Thyroid
disorders
condition.
then
and PID, sir, primary immunodeficiencies like severe combined
or
immunodeficiency. And
though there is no history of
infection,
this thing,
recurrent.
fever or anything, these children, those who have malaria at this age, they may not present with children, they may present with pallor also. Okay.
Yes,
Then
sir.
you have
Colors.
torch infections.
Okay, sir.
They may also present, but their history is at birth they will have neonatal jaundice, and then mm, there will be other features when you examine. Okay, we'll go to the examination part and then we'll discuss
Okay, sir.
all that. Treatment history.
The child has been receiving 20 ml per kg of PRBC every 18 to 20 days. After 9
Okay,
to 10 months of initiating regular blood transfusion, the child was started on the single ion chelating agent to reduce serum ion level. However, due to the persistent elevated ion level, a second ion chelating agent was added at 2.5 years of age. Child takes
okay,
vitamin D once a month and folic acid on alternate day. The pre-transfusion hemoglobin is around 9 to 10 gram per day.
okay. Vitamin D once a month. Okay, fine. Earlier they used to say that all the case that you are presenting should receive vitamin D every month. Nowadays, TIF says that it should be once in 2 months. Okay,
Okay, sir.
right. And 20 ml per kg of PRBC. Fine. Okay. Next, what else is he taking?
So there is a no history of recurrent unexplained fever, rash, breathing difficulty post transfusion. There is a no abnormal facial features. There is a no history of chronic diarrhea, stomach pain. There is no history of recurrent infection.
How do you explain facial features? Why did you ask for them?
Uh,
Recurrent, what are the conditions that will require recurrent blood transfusion?
Sir, recurrent blood transfusion.
Otherwise, a normal looking child.
Sir, thalassemia major, aplastic anemias,
Okay.
and
Hmm.
there is a Diamond-Bachmann syndrome, uh,
Hmm.
and then
Sickle cell.
severe sickle, sir, not normal.
Sicklers. How do you differentiate sicklers from these? Sicklers, if it is a severe variety, will require regular blood transfusion. Sicklers don't require that frequent transfusions. No?
Yes, sir.
They have those crisis period and then only they
Uh,
are transfused. What are the other findings that you will have, or in the history you will have for sicklers. How do you differentiate from thalassemia and sickler? If I'm visiting.
Sicklers have pain crisis, intermittent pain
Yes,
crisis, and they are
yes,
mostly icteric and
yes.
jaundice. There is
Intermittent jaundice will be
jaundice
there,
will be there.
or there
Uh,
is history of dactylitis,
okay, sir.
swelling and pain of the
Small joints of
finger joints.
finger joints.
That's why they are generally put on prophylactic
Hydro.
antibiotics, penicillin they are given. No?
Okay.
Okay. और क्या होता है सिकलर्स में?
There is a leg
Recurrent
ulcer,
pain
sir.
abdomen they may have because of the crisis. That's why there is autosplenectomy. Do you have spleen palpable in sicklers?
No, sir, very rare.
Initially may be there, but automatically with
Autosplenectomy.
autosplenectomy. That's why you say that they have autosplenectomy. Okay, go ahead.
There is a no history of recurrent infection, easy bruisability. There is a
Yes.
no complaint of skin hyperpigmentation, growth retardation. No complaint of bony pain or pathological fractures. No complaint of polyuria, polydipsia, or any hypothyroidism features like there is a cold intolerance and weight gain. There is a no history of recurrent jaundice, abdominal distension, or bleeding manifestation. No complaint of pedal edema, palpitation, or the exertional breathlessness, and no complaint of limb swelling, pain, or sudden onset of chest pain.
Okay, you asked generally all the questions.
Yes, sir.
By the way, tell me, since you are discussing thalassemia today, tell me, when do you start getting these complications of thalassemia, like endocrine complication? When do you expect?
Sir,
Do
endocrine
you
complication
expect at this
generally,
stage?
no, sir,
4
after
years
8
of
to 9
age?
years. After 8 to 9
Yeah,
years of age.
generally after 10 years, except hypothyroidism, which may present early. Earlier, we used to go for endocrine profile after 10 years, which we still follow. But thyroid, we start getting done after 6 years now. Okay. And similarly, cardiac problems
10
and
years after 10
these
years.
problems. The first organ to be affected is
Liver, sir.
liver. And then nowadays, we believe that pituitary also gets affected very early.
Yes, sir.
But it manifests later
Later.
with delayed puberty and other features. Okay?
Yes.
चलो आगे चलो.
Child is born out of non-consanguineous marriage. There is no history of regular blood transfusion in family or any blood-related disorders. So this is a
Yes.
3-generation pedigree chart of the family.
Yes. Tell me, what are the communities or this thing where this places or communities where thalassemia is more common?
Sir, it is more common in Punjabis, Sindhis, Gujaratis, and mostly in the North Delhi's and Sindhi, Gujarati.
Yes,
And
it is. Beta thalassemia is more common in North and West India.
West.
Okay, in South India we have less thalassemia, and in eastern part of India we have HbE problem. E thalassemia. That is a hemoglobin variant E, like as E is also. And there is one. What are the other hemoglobin variants? Can you name one or two?
Sir, there is a HbH, HbS, HbC, HbE.
C is not, remember, by the way, I'm just telling you. C, we don't see that commonly in India. It's commonly found in African countries. What common conditions, hemoglobin variants? There is one called D Punjab.
Yes.
There is one called Q India.
Okay.
They are seen, though they are, most of them are very benign variants of hemoglobin. Okay, but E is a problem sometimes, S is a problem. And D Punjab generally is not, though many people keep arguing that homozygous D may present with all this. Never, it never causes any. Okay, so you asked from that point of view. Communities, you rightly said, Sindhi, Punjabi, Gujarati, Maras, Saraswat, Gods, and all. There are so many. But with the intercaste marriage, now there is no community which where we don't see this thalassemia.
Yes, sir.
Okay, all we have got Jains also, all Sikhs also. We have got so many Sikh patients and Muslim patients, all communities and religions. This thalassemia, and there is no country in the world where thalassemia is not found because of the migration of people going back. What is the incidence of thalassemia and what is the prevalence of thalassemia? Tell me the difference.
The prevalence is the past and present cases, that is 3 to 4% in the India, sir.
Yes, prevalence is of the minor cases which are present in India, okay, or means existing cases. Incidence is,
The new cases.
yes, incident number of cases are taking birth.
Mm.
So, what is the incidence of thalassemia in India? Major births. Around 10 to 15,000 per
Okay,
year.
okay, sir.
In spite of all the efforts that everybody has made in India, still there are so many cases occurring because there is no regular screening at this in the antenatal period. Okay, now we have come to this. Generally, you will find one or two cases in the family, distant relatives, or somebody getting regular transfusion, or some. What happens to thalassemia minor in pregnancy? Did you ask his mother what happened to her during pregnancy?
Sir, actually, mother and father both are the minors, but they didn't know they were
They will
minors.
have to be minor.
Yes, sir.
Otherwise, you can't have a
Yes.
thalassemia major baby.
Yes.
Remember,
Yes.
okay? So
Yes,
no
sir.
question. They are obligate minors. वो
Yes,
तो
sir.
होना ही होना है ना, because नहीं
Yes,
तो
sir.
बच्चा कैसे होगा उनका major?
Yes,
ठीक है
sir.
ना? Right. So what happens to minor? Most of the minors, you know, what is thalassemia minor? They are normal people. They are
Yes, sir.
not having any disease or illness. They are normal people of the society, except that majority of them will have slightly less hemoglobin between 9 and 11.
11.
And during some stress period or crisis period, their hemoglobin may drop. And that stress period comes
Pregnancy.
that is pregnancy.
Pregnancy.
So you should ask the mother, did you have very low hemoglobin? Because most of the time when hemoglobin drop, people give them iron.
Iron.
They keep loading them with iron, but the hemoglobin may not rise beyond a particular limit. Then some of them, few of them may receive blood transfusion also.
Okay, sir.
And one thing, all of you please note that thalassemia minor is not an iron overloading condition.
Yes.
Yes, sir.
So thalassemia minor, especially during pregnancy and otherwise also, if they have iron deficiency, they should be given iron. होता क्या है कि थैलेसीमिया का नाम सुनते ही आप आयरन तो बिल्कुल अलग कर देते हो ना, इसको तो देना ही नहीं, even if he is minor. That is not correct. Thalassemia major is an iron overloading condition. Minors are not. They don't get iron overload. They should be given normal iron. Like all tell minor pregnant females should get their iron during pregnancy. They should not be. We should not withhold iron from them.
Yes, sir.
Okay.
Yes, sir.
And you've rightly given. When you give this pedigree chart, then you should take 3 generations at least,
Yes, sir.
right? You know that? Okay.
Yes, sir.
Was there any consanguinity? No,
No,
non-consanguinity.
sir.
How do you represent consanguinity in this?
Sir, double line between the marriage.
Double line. Right, fine. Next.
Antenatal history. The first trimester was uneventful. There is a pregnancy detected by UPT, booked case. The injection TT was given. Dating scan was normal. Tablet folic acid and
ठीक है
calcium
ठीक है
were
ठीक है
taken.
ठीक okay
The
fine
second and third trimester pregnancy, the trimester also uneventful.
okay
Birth history, it was LACS in view of previous LACS. Birth weight was 2.7 kg and baby was cried immediately and there is no
Okay.
NICU stay.
right next
And developmental history, there is no developmental delay. So child is appropriate
चलो
for
ठीक है
age.
ठीक है you have taken full detailed developmental history
Yes, sir.
and his milestones were normal
In
immunization
immunization,
history
child was immunized till date as per IIP schedule. He also taken the
very good
extra vaccines according to IIP, and the last vaccination received on 18 months, sir.
okay
According to socio-economical, child was lower middle class as per Kupuswamy scale.
where is he taking regular transfusions
Sir, in our hospital only.
he is okay fine that's good
The feeding history, a child was mixed diet, veg plus non-veg. Child was taking adequate calories and child was 18% protein deficit. Fluid intake was 1800 ml of water plus 400 ml of milk.
okay 1800
Sorry, 800, sir.
नहीं तो ज्यादा नहीं हो जाएगा
Yes, sir. Yes,
चार
sir.
4 years old child taking 2.5 liters of water
No,
every day
sir. Sorry, sir.
he'll be just passing urine all the time
Yes, sir.
okay
The 4-year-old child is known case of hematological disorder which required regular blood transfusion with no history of no significant family history and has been receiving blood transfusion since 3 years of 1 year of age. Sorry, sir, 1 year of age, along with 2 oral iron chelators and with no significant birth history, developmental history, or immunization history.
yes now you come now what do you think it could be possibly we have already discussed it
Yes, sir.
it could be
So it could be a hemolytic condition like thalassemia
Yeah.
major.
thalassemia major should come to you first a child who is on this thing regular blood transfusion
transfusion.
without any problem otherwise no other issues should be thalassemia then you can say that aplastic anemia will also present like this sickle cell we have already discussed then pkd pyruvate kinase deficient it is pyruvate kinase deficiency ठीक है enzymopathies में you have written the number B
Yes, sir.
PKD is another condition which is a rare condition difficult to differentiate from this and only by doing enzyme assays you can find. But if you have ruled out the thalassemia and other conditions, then only we think of that condition. What happens to G6PD? Tell me.
Sir,
Do they require regular blood transfusion?
No, sir.
Okay.
Never.
No, sir.
They are only they react to certain things
Only drug
because they have deficiency of in their RBCs of glucose 6 phosphatase dehydrogenase. So they have D6PD deficiency and then they will immediately hemolyze when they are exposed to those items. Okay? So intermittent they may have it. Hereditary spherocytosis we have discussed.
Yes, sir.
One thing they have is good spleen, very large spleen.
Yes, sir.
Okay. Nutritional anemia, iron deficiency anemia may present, but they will never require regular blood transfusion.
Yes, sir.
Or marrow infiltration defect, okay, that will be
Or the infections
leukemia,
like
but child will be very sick. A
Yes.
child with aplastic anemia and leukemia, infantile leukemia, if they grow to this age, they will have many more events and episodes, other episodes. Torch infection, which you did not mention, and in India, always you should think of TB also, but
Yes, sir.
none of them will require regular blood transfusion like this. So bone marrow failure syndromes, right. Or you can have aplastic for some time, and then aplastic can have But aplastic will have thrombocytopenia also, leukocytopenia
Yes, sir.
also. So they will present, they have their manifestations also. Okay,
Yes, sir.
chalo, next.
On general examination, after taking
Right.
parents' consent, child was examined in supine position. The pulse rate was 88 per minute in left radial artery in supine position. There was no radial or radiofemoral delay. Respiratory rate
Hmm.
was 24 per minute in abdominothoracic type. The BP was
Hmm.
80 by 50 in supine position in right arm. It was between 50 to 90 centile as per age and sex. The SpO2 was 98% on room air. Temperature was child was febrile, measured in the right axilla. Pallor was present, but there is no icterus lymphadenopathy, edema, or cyanosis.
Right.
In head-to-toe examination, the hair was normal, eyes was normal, oral cavity shows no ulcers or pharynx is normal, no prominence of the cheekbones are seen.
Can you explain hemolytic or what we call thalassemia phases, since you are now thinking in lines of thalassemia? So what are you looking for?
Sir, in the thalassemia phases, there is a prominence of frontal bone. There is a
Yes.
depressed nasal bridge. Then there is a
Hmm.
malocclusion of teeth, and there is a prominence of lower jaw.
Yes, maxillary prominence from forehead prominent, then malocclusion of teeth when they start getting them. Okay, because that is expansion of the bone marrow in all
Yes,
these
sir.
places, right?
Extrapoetic hematoma.
And what happens in the skull?
Uh, in s- there is
Parietal prominence, which
parietal.
we nowadays don't see because we start transfusing them early. If we transfuse them late, what used to be called hot cross bun appearance. And when you take X-ray, what do you see in the X-ray?
Hair on it.
Yes, hair on end
Yeah.
appearance. ठीक है
Heron.
डॉक्टर राज आप पूछिए ना मैं तो आपकी जगह पूछ रहा हूँ सारा कुछ
Yes, sir.
हाँ जी बोलिए
Okay, sorry, sir. Neck, there is a no swelling, there is no lymphadenopathy, chest, abdomen, limbs
right
were normal, spine and nails were normal, there is no dryness observed, or there is no hyperpigmentation of skin.
yes
Anthropometry,
what kind of pigmentation do you get because of iron overload?
sir, grayish pigmentation, sir.
Yes, grayish black pigmentation.
Grayish.
Generally, we have dark colored people, dark skinned people also, and in fact, we are all dark skinned. But that family texture is not there of the skin. No?
Yes, sir.
Family color, complexion is not there. It is real grayish black color. That is because of
Iron
deposition of
deposition.
iron and stimulation of the melatonin.
Yes, sir.
Both things together. Melan melanocytes and
Hyperpigmentation.
the
Iron
iron
deposition.
deposition. ठीक ओके और चलो आगे
The
weight
weight is 16 kg between 50 to 50 centile.
yes
Height is 98 centimeter between 25th to 50th
how
centile.
much is the expected at this age
Expected is, sir, almost 100 centimeter, 100 to 102 centimeters, sir,
yes
at 4 years old.
around 100 centimeter weight is okay for his age 16 is the expected weight and mid-arm
Mid-arm
circumference
is 12.5, little on lower
more
side, sir.
than it should be
13.5, sir.
yes 13.5 12.5 and 13.5 is borderline
Borderline.
okay next
This is the IRP chart showing
yes
the weight for age and height for age, sir.
yes
On systemic examination per abdomen, the shape appeared normal. Umbilicus
hmm.
was center in position normal in shape. No visible pulsations or scar. No distended veins. Herniation orifice appear normal. External genitalia appear normal.
Good. Hernia
On
sites, even if it is a case of thalassemia, you should always mention because it's a part of abdominal examination.
examination.
ठीक?
On palpation, the abdomen feels soft on palpation, no tenderness. Local temperature was normal. Liver is palpable
Hmm.
about 4 centimeter below right mid clavicular line. which it was firm in consistency, rounded margins, no tenderness, and liver span was 11 centimeter. Spleen is
Right.
palpable about 3 centimeter below left
Its surface is smooth always. The
Yes.
liver will be firm in
Yes,
feeling, and the surface is smooth.
smooth.
Okay.
3
Spleen,
centimeter.
where do you how do you explain the growth of spleen? It grows in towards the
Right iliac fossa, sir.
right iliac fossa. It doesn't go straight down. It goes towards right iliac. And how do you measure? Mid
In
clavicular line to
in
the tip of
diagonal direction,
yeah
we start palpating
to the
from the
tip
right
of
iliac
the
fossa.
spleen maximum distance. ठीक है?
Yes.
Notch was palpable. Good. Okay.
On auscultation, the vowel sounds heard normally.
Fine. So this child has got hepatosplenomegaly
Megaly.
and is on regular blood transfusion since the age of around 1 year. Right?
Yes, sir.
Do
And
you expect some facial changes when they delay blood transfusion till
yes.
1.5 years?
Yes, sir.
Sometimes they may develop.
Yes,
It
sir.
depends what was the hemoglobin at the time of
Transfusion.
transfusion. How many types of thalassemia is there?
Sir, there is a
Today we know
thalassemia
of
mutation, sir.
how many mutations?
More than 600, sir.
More than 300. Some
More than,
people say
300.
350
Okay,
mutations. We know. So it depends on the type of mutation, beta plus, beta minus, beta plus plus.
Yes.
So what and the age of presentation that we say. And then if the hemoglobin has been low for a very long time, it had been low, then they will develop facial changes
Hemolytic
because
test.
of extramedullary hematopoiesis.
Hematopoiesis.
ठीक है?
Okay.
So we should start them early on transfusions.
Yes,
If
sir.
we are sure of the diagnosis of thalassemia major.
Yes,
चलो
sir.
जी आगे.
In CVS examination,
Yes,
there
they
is
have.
no, all
Okay,
other system
all
were
of them are
normal.
normal. Fine, we don't waste time on this.
In
So in
summary,
summary,
the
yes,
4-year-old female child is known case of hematological disorder which required regular blood transfusion with no family history and has been receiving blood transfusion since 1 year of age along with 2 oral iron chelators and with no significant birth history, development history or immunization history with hepatosplenomegaly.
this is called copy, cut and paste. You have made the same mistake earlier,
Yes, sir.
3 years of age,
Yes, sir.
and you copied it here also.
Yes.
Right. ठीक है, पढ़ लिया करो
Yes,
before
sir.
you present. Provisional diagnosis is
The
transfusion dependent
transfusion-dependent
thalassemia. Earlier we used to call them
thalassemia
thalassemia major. We all still call them thalassemia major, but the new terminology for the last 15-20 years is TDT, thalassemia. What is the other?
NTDT,
NTDT.
non-transfusion dependent thalassemia.
What does it include?
It includes thalassemia intermedia, sir,
Or?
and thalassemia minor.
No.
Oh, sorry.
You cannot label thalassemia minor as NTDT. It includes thalassemia intermedia and hemoglobin E disease, milder form. Severe will definitely require regular blood transfusion. But E is such a, you can say, not a very well recognized, means understood, not recognized, that will be a wrong word. Well, it is not that well understood disease. See, same mutation, HBE disease. We have 2 children. One getting regular blood transfusion, other not getting any transfusion.
Yes.
Same mutation. So E can, and one thing peculiar about hemoglobin E is that E beta thalassemia may tolerate lower hemoglobins better than these thal intermediate. और कौन सी बीमारी आती है इसमें बोलो?
HBH, sir.
HBH disease. Okay. Some people do not include HBS disease. There is one condition called
HBS, the thalassemia
SBS
plus
disease, sickle beta thalassemia. We don't include because their presentation is more like, their behavior is more like sicklers. तो इसलिए कम इंक्लूड करते हैं इसमें. और बोलो. चलो. Next.
Yes, sir.
Do you have any other slide? Yes.
Yes, sir. This is the CBC done on 7th of August, which
Oh,
shows
yes,
the
recent.
HB around 10.7, TLC
This was
12.
pre-transfusion hemoglobin.
Yes, sir, pre-transfusion hemoglobin.
Okay. So your case is most likely thalassemia major only.
Yes, sir.
So how, if a child comes to you after receiving transfusion, how do you confirm the diagnosis of thalassemia major?
Sir, we generally wait for
And
7
general,
to 10
first
days.
time, like, no, I'll put it in another. If a child has come to you with, like mother has brought to you a child, 7, 8 month old with severe pallor,
Yes, sir.
and you examine, you find spleen enlarged, liver mildly enlarged.
Yes, sir.
How will you proceed?
Sir, first I will look for the CBC. In CBC,
Yes.
I will look for the HB, then RBC count and MCV and MCH. If
Yes.
there is a MCV is there is a microcytic microchromic anemia, then we will go for the mostly
But
iron
in
or
these cases, I'll tell you one thing. In these cases, in thalassemia, that what you are telling it, that holds true for minor. That's how you calculate Menzer index, and that's how we differentiate them from. What is Menzer index?
Sir, MCV divided by RBC. If it is more than 13.5, it is iron
Yes, yes.
deficient.
13 and bus, not
Yes.
0.5.
Okay, sir.
If it is more than 13, likely to be iron deficiency is less than 13. Now, see, in thalassemia major, the peripheral, what is the peripheral smear like?
Sir, in a major, there is a teardrop cells, then there is a target
Yes,
cells,
teardrop cells,
then
and
Howell Jolly bodies will be present.
yes,
Then there is an isopoikilocytosis.
yes. So all these things you see. So these are RBCs. They don't mature to the stage of reticulocyte count and mature RBCs. They are destroyed early in the bone marrow. So these MCV, MCH may not be holding true. What you see, you will find more of nucleated RBCs.
RBCs, Howell Jolly bodies.
Yes. And why is this? You said teardrop cells. What are they?
Sir, they are the destroyed RBCs.
Why do they look like teardrop?
Because of the there is a deposition
Target
of
cells,
alpha. Yes.
not teardrop. Teardrops are because of the hemolysis. Target cells are seen in these cases, and target cells are because of the, when you make a film, peripheral smear, target, when they settle, the hemoglobin comes in the center, and because of the loose RBC membrane, it gives the appearance of target.
Target.
You know target?
Yes, sir. There is a central dark and
Dart wala
peripheral.
target.
Yes,
Wala.
sir.
So it gives the appearance of that. So TLC may be high, hemoglobin may be low, and what happens? Peripheral smear, most of the time, an experienced hematologist will give you his opinion as, please investigate the child for thalassemia, or they will write peripheral smear suggestive of hemolytic disorder, possibly thalassemia. So how do you confirm the diagnosis?
The HPLC. And there is
Yeah.
after that, there is a mutation analysis.
Yeah, HPLC, what will you find?
Sir, in thalassemia major, there is a 90 to 92% of HbF
Yes, okay.
hemoglobin.
Fetal hemoglobin is raised.
Yes, sir.
And if a child has received blood transfusion before coming to you, mother says कि एक blood तो लगवा दिया था हमने. What will happen to that? Fetal hemoglobin will not come raised now.
Yes. Then we have to wait for
Books say
7 to
that you
10
should
days.
wait for 2-3 months and then
Okay.
repeat the fetal hemoglobin. But
Okay.
indirectly you can confirm the diagnosis at that time indirectly by getting both the parents tested. If they are both minor and you are
Yes,
thinking
sir.
of thal major, it's likely to be thal major. Or you go for
Molecular analysis.
yeah,
Molecular.
molecular analysis or the genetic test, because waiting for 3 months and then still we have seen in our practice that it doesn't come back to the original normal with those original hemoglobin findings. Okay?
Yes, sir.
So that's the different the diagnosis of thal major. Okay, how do you differentiate thalassemia major from go back, go back. You written target
Sir.
teardrop cells, target cells, and then you have those ovalocyte, microcytic hypochromic anemia, and isopoid
Yes, sir.
kelocytosis. Fine. So next, how do you differentiate thalassemia minor? How do you confirm thalassemia minor? First thing is
The in thalassemia minor, for the confirmation,
first is screening for
yes,
thalassemia minor.
HPLC and
Screening is
HPLC.
no screening
No,
is by
screening is
CBC,
CBC.
Yes.
Yes, sir.
and you can look at the MCV,
Meissner's.
MCH. MCV less than 80, MCH less than 27 will give you an idea that it's likely to be
Thal minor.
thalassemia minor. Provided no, it's a hypochromic microcytic anemia,
Yes,
which
sir.
may be iron deficiency.
Yes, sir.
Then next is you look at
RBS,
RBC count.
RBC,
If
RBC.
RBC count is normal
High.
or higher on the higher side,
Then
then
it
you
is
will have
thalassemia minor.
thalassemia. If it is on the lower side, it is
Iron.
because the RBC production is less in thalassemia
Yes, sir.
in iron deficiency, and it is proportionate to the hemoglobin level.
Yes, sir.
In now, what happens if in thalassemia minor hemoglobin is 9, but on the other hand RBC count is higher? They are disproportionate,
Yes, sir.
and MCV is also disproportionately low. In iron deficiency anemia, if the hemoglobin is 9, we expect MCV will be around, say, 70, 75, like that. But in thalassemia, you may find MC with 9, 10 grams hemoglobin, MCV may be 65, 60, like that, 62, like that. Okay. Then next is you look at
Sir, HPLC.
RDW.
Oh, sorry, sir. RDW.
What happens to RDW in
Increase, sir.
thalassemia and iron deficiency anemia?
Increase, sir.
Hmm?
Increased.
In iron deficiency, it is increased. In thalassemia, it is
Decrease. Or
normal.
normal.
Okay. So, how do you differentiate? And then you confirm the diagnosis by getting the serum iron done. And on the thalassemia, you confirm by getting the HPLC done
HPLC.
or hemoglobin electrophoresis, where hemoglobin, which one is raised?
HbA2, sir, raised.
How much?
Raised. It is between more than 4.5 to 8 till 8.
No, it is more than 3.5, the standard teaching,
3.5.
but
Okay.
3.5 to 4, they take as sometime as intermediate. But if it is 3 to 3.5, remember, if the child is having iron deficiency, severe iron, in mild iron deficiency, HbA2 is not affected. In severe iron deficiency, A2 may be affected. So you may have, and you correct the iron deficiency in that case for 3 months and repeat it after that. Okay?
Yes, sir.
Chalo.
So this is
So
HP
now you know how to differentiate iron deficiency from
thalassemia
thalassemia minor.
minor.
Now, what is this thing showing? This child's electrophoresis at the time of diagnosis.
HbF is 91.3%, sir.
Okay.
And
Fine.
the parent HPLC, father's HbA2 is 6.3 and mother's HbA2 is 4.3.
Okay.
And this is the mutation analysis, which was showing
IBS 1.5 and IBS 1.1.
1.1.
So double heterozygote, compound heterozygote, you can say, because
Yes.
both the mutations are different. Right?
Yes.
Which is the commonest mutation in India?
IBS 1-5, sir.
Yes. What are the other mutations? 5
IBS 1.
कॉमन म्यूटेशन होती है ना इंडिया में 5-6.
Yes, sir. IBS 1-5, IBS 1-1, codon 41, 42, then codon
Yes.
8-9,
8-9
and there is a deletion of 619.
Yes, very good. Very good. Chalo. They form almost up to 90% of total thalassemia cases in India. So if the person is not falling in these 5 mutations, then we have to go for sequencing and look for the uncommon mutations.
Okay,
ठीक है?
Yes, sir.
Chalo, next.
So this is the ferritin level, which is almost always more than 1,000 to more than 1,000. That's why we are added one more oral chelator for this child. So right
Before
now,
adding, what are the other things that you should make sure? No,
sir,
chelator बाद में करेंगे. चलो पहले.
okay.
What is he getting? Blood transfusion. Common management from PG point of view. We don't expect you to have a very detailed knowledge about thalassemia, but basic things you should know. What is the pre-transfusion transfusion? Now, how will you manage this case? You have
Sir,
diagnosed him as thalassemia. You confirm he's got double heterozygote 2 mutations of thalassemia IVS-1-1, IVS-1-5.
then I'll test child for HIV 1 and 2. Then
Baseline
HCV.
test you will go
Yes,
for.
sir.
Yes. And you
Uh,
will go for anti-HBS also.
Anti-HBS
So that
titer and
he's
HCV
protected
antibodies.
against. And then?
HCV antibodies. Then we
Yes.
will
Then
do.
before transfusion, you should do the detailed phenotype blood group.
Yes, sir.
So you know that whether he is C positive, C negative,
C,
Cal positive,
E,
Cal
and K.
negative. Okay.
Yes, sir.
Then you put
Then
them on a regular blood
blood
transfusion.
transfusion. The target HB pre-transfusion is between 9.5 to 10.5. We targeted for
Fine.
9.5 to
Yes,
10.5.
yes.
Then after 10 transfusions, we will check for the serum ferritin level. If it is more than 1,000, then we will start child on the oral iron chelating agents.
No, अभी तो blood transfusion पे ही रहो, Dr. Mithila.
Yes, sir.
How much blood do you give?
Sir, we will start with 5 ml per kg per hour. We will give maximum 15 to 20 ml per kg blood.
Yes, generally. And how much rise in hemoglobin do you expect?
Sir, for 5 ml per kg, 1 gram of hemoglobin increases. So for 15 to 20 ml,
That is for 60% packed cells. What we normally use is 60%.
60% packed cells.
We leave little plasma so that RBCs can survive for some time. Because RBCs don't have nucleus, so they survive on the plasma that you leave in that. If you make very tight packed cells, then their life is not there. Okay?
Yes, sir.
Fine. Before you transfuse them, we should do a detailed cross match.
Yes, sir.
With the phenotype. Phenotype cross match should be done. What are those? 5, 6.
RH, then C.
ABO, RH, everybody is doing. But in now many centers, we started doing.
E and K.
Capital E, small e. Capital C, small e, and Kel. Some others do Duffy and others also. That's a good thing if they have the facilities or kit to do that. So we should give them phenotypically matched blood. What is the rule of 30 minutes and 3 hours or 4 hours?
Sir, we should start transfusion within 30 minutes.
Yes,
and,
from the issuing, it
transfusion
will reach the blood bank, from blood bank to the unit within 30 minutes it should reach. And then we should
completed within
transfuse
4
them
hours.
immediately. Do you warm the blood before you give
No,
them?
sir. We don't warm because
Earlier
it
what people
causes
used to do,
hemolysis.
they would keep them that blood bag in the towel and shake it and warm it. No, not at
No,
all.
sir.
Never do it. Okay. Do you pre-medicate them
No,
with
sir.
Avil or
No, sir.
some
No need
antihistamine
of.
or steroids? No.
Okay.
Unless child has got severe allergic
No.
reactions, we don't give them. Okay. There's no routine pre-medication required. After transfusion, do you give them antimalarials?
No, sir. No
No,
antimalarial, no Lasix.
because nowadays we have got very good kits to check what are the tests that you perform on donor blood before giving it.
Sir, HCV, HIV 1, 2, HCV, HBV, then syphilis and malaria.
Yes, these 5 tests are mandatory. Nobody can issue blood in India without doing these 5 tests. Earlier, they were doing by malaria by smear method, which was not that sensitive. But nowadays, they are using the so
That,
acha.
that,
Or
that nucleic acid.
now interval, 2 to 4 weeks, as convenient to the patient as well as to the doctors, means
Yes, sir.
your unit also. Okay.
Then we
Now,
should transfuse the
what
fresh blood.
happens? How much iron is there in the blood?
Sir, one bag has 200 milligram of iron.
Roughly.
Yeah.
To be very precise, tight packed cells contain 1.16 milligram of iron, but you can say roughly 200 milligram of iron per pack. And unfortunately, our body has no mechanism to remove this iron, so we have to take help of the
Oral
medicines to
chelators.
remove, and they are called chelators. Not oral, we have injectable chelators
Yes,
also.
sir,
In
yes.
fact, the first gold standard for chelation was
Desferoxamine
desferol,
injectable.
injectable. Okay, so what is the ferritin level that you consider before starting the chelation therapy?
Sir, we want to keep the ferritin less than 1000. Whenever it is more than 1000, we have to start chelation, sir.
Yeah, we want to keep it between 500 to
1000.
1000. And there are 3 chelators nowadays available. The first one to be tried was desferol.
Desferoxamine.
The problem with desferol, disadvantages of desferol.
Sir, short half-life, 20 minutes of half-life.
Yeah, you have to give it in a continuous,
As
either
infusion.
subcutaneous or intravenous. Nobody can give intravenous unless patient has got cardiac involvement. Nobody gives. Otherwise, we used to give, or still in many cases, we give subcutaneous with the help of pump. It is given over 8 to 10 hours period. So, why desferol has to be given subcutaneously or parenterally, I mean, because it has
oral
got a very big
bioavailability
molecule.
not.
It's not absorbed orally. अगर याद करो, iron poisoning में we used to give desferol orally. That was for binding in the gut.
Yes, sir.
So otherwise,
Non-absorbed
to
iron.
remove it, iron from the body, we have to give it parenteral. It's very expensive drug. What is the cost of now? We get now that 500
15,000.
milligram of vial, na?
Yes, sir. Around 15,000.
No,
No, 15,000 for a month, I think. I don't-
it costs 300 rupees per vial. It depends on the age of and weight of the child.
Yes, sir.
ठीक है ना? Earlier it used to be 180 rupees for 20 years. It was 180. Now they have increased the price to 300 rupees per vial. So the dose is
Dose is at 20
20
to
to
40
40 in children and 30 to 50 in adult.
adult.
So even if you give 30, 40 milligram to a, say, 30 kg child, 30 milligram means 2 vials. 2 vials means 600 per day. That means almost 2000 plus cost of that butterfly needle and all those things you have. So it costs around 25, 30,000 rupees a month. Very expensive.
Yes, sir.
So, and traumatic तो है ही है, because what are the side effects of desferol that you have read?
Sir, visual side effects, then the
Yeah, they all these.
ototoxicity.
See, one thing good was that desferol is a relatively safer drug, but most of the side effects because of
Dose
desferol are dose dependent.
dependent.
हमारे तो बच्चों को आयरन इतना कम होता ही नहीं कि excess of desferol can be used in them, because
Yes, sir.
for that you have to. So there were few side effects, but the main problem was cost and trauma of
Yes.
injections. So when this was the only drug available with us, only 2% of our patients were receiving desferol chelation, adequate chelation. Then came another chelator. What was that?
Sir, Defriprone.
Yes, Defriprone is available as Calfer.
Calfer.
Cancel.
It is available as 500 and 250
250.
milligram capsules. It is
Caps.
not available as tablet.
Yes.
Outside India, it is available as syrup also, Feriprox syrup. Okay, but in India we have capsules only. But it is orally effective, very small molecule. The advantage of this is that
It can go to the myocardial, cardiac
yes,
muscle.
yes, it can penetrate the myocardium easily. Very easily it can penetrate the myocardium. So it can chelate iron from the heart
Heart.
much better than other two chelators.
Yes.
But the side effect, dose क्या है इसकी?
Sir, 75 to 100 mg per kg.
Yes, you start with 75 and go. What are the common side effects that you see?
Sir, bony pain, arthritis is most
Bony
common, but
main arthritis and
arthritis.
arthralgia more common than arthritis. Once a
Arthritis.
child gets arthritis with Calfer, we don't give it again because
Yes.
that can lead to permanent disability. Okay?
Right.
Or
Yes. Then neutropenias and granulocytosis.
yes, agranulocytosis is a very dangerous side effect seen in about 1% of these cases.
Yes, sir.
One can lose a patient also. ठीक है, agranulo. See, 1% is not a rare side effect. If
Yes,
you
sir.
see from our point of view, doctor's point of view, because if you remember chloramphenicol, have you read about that drug?
Yes,
Do you
sir.
know chloromycetin or chloramphenicol?
Chloramphenicol. Yes, sir.
Yeah, that used to be given for typhoid,
Yes.
and it used to give gray baby syndrome, but that drug was used with a lot of restrictions because it had the side effect of this again suppression of the bone marrow. But in rare cases, here it is 1%, which is common. So we have to be very careful, and monitoring, strict monitoring is the most important thing in when you are using Calfer. Now, which is the third one?
The Deferacirox, sir.
This is a new addition.
Defrigel.
It was introduced in the West in 2005. In
2005.
India, it arrived in
2007, I think.
yes, 2007. We got this drug in India on March 31st, 2007. It's a relatively good, safer drug, and it is the first line of management or the drug of choice for a beginner in
Yes.
thalassemia. So it has got a long half-life.
Half-life.
So once a day dose is enough,
Yes.
right? Its dose is
Sir, 20 to 40 mg per kg.
Yeah.
And for the
Yes.
coated capsule, it is 14 to
Yes.
28 mg per kg.
Yes, roughly two-thirds of that. Okay. So see, your patient may say that see, those who are on Desferol and Calfer, they say that we get red urine immediately after taking the medicine. Why?
Because it excreted iron from the urine, sir. That's
See,
why
in case of Desferol, the excretion is mainly by urine, but by feces also.
Yes.
In Calfer, it is mainly by
It is from
urine.
feces.
No, in
Sir.
Calfer, it is mainly
By
from the urine.
Urine.
Only in cases of Defrosirox, Asunra or Defrijet or Desirox,
Yes.
it is by feces. So the urine color is not changed. So
Yes.
tell them not to get worried. Okay? Chalo. So you have to keep the and see the main thing with chelation in thalassemia is you have it's the compliance with the
Yes,
treatment,
sir.
adherence to the treatment, since it is a lifelong treatment.
Yes, sir.
So they give up the treatment in between. They just don't comply. They find they look for a small reason not to take this medicine. So you have to motivate them, keep telling them that this is necessary, and look at their ferritin level and explain to them repeatedly. Okay.
Yes, sir.
What else is there in the treatment? What all vaccines they must get these thalassemics?
Sir, additional vaccines like pneumococcal, then chickenpox
Yes,
vaccine, then
yes.
influenza, uh,
Hepatitis A,
hepatitis A,
टाइफाइड हेपेटाइटिस
typhoid.
बी तो कर देना ही है सबको
Yes, sir.
before the first transmission. They must get hepatitis A, chicken pox, and typhoid vaccine because
Yes,
it can, and flu vaccine also,
yes, sir.
especially those who are splenectomized.
Yes, sir.
ठीक है? So this is the day-to-day management of thalassemia. Dr.
Yes.
Raj, you want to say something?
Yes, sir. I wanted to ask, what are the long-term complications of thalassemia major, and how is it different from thalassemia intermediate?
Yes.
Uh, In thalassemia major, the mostly side effect involving the because of the deposition of iron in the liver and the heart, along with the endocrine organs like thyroid and the gonads. In intermediate, the complications are because of the stasis of the blood, and there is a thrombosis and the thrombophilia. That's why there is a leg ulcers, and there is a chances of infarct. Uh,
Very good. Very
Yes.
good, Mithila. See, in thalassemia major, most of the complications are because of the repeated blood transfusions. Complications of blood transfusions are always there. Transfusion transmitted infections. Then you have transfusion reactions, iron overloading, which is inevitable complication of blood transfusion. And because of iron overload. These are complications of thal major. In intermedia, the complications are because of anemia, bone marrow expansion, then
yes,
abnormal RBC or platelet circulation, which may give rise to thromboembolic complications like leg ulcers may develop because of chronic anemia, thinning of skin, and thrombosis. Then pulmonary hypertension. Then you may get extramedullary hyperplasia like paraspinal masses you may get. So these two, the conditions, some people say that these two conditions are totally different conditions. They behave differently.
yes, sir.
ठीक है? So
Yes.
complications, causes of complications are totally different. Anything else, Dr. Raj?
The newer drugs that are
Yes,
now available for thalassemia. There are a
yes.
few drugs that have
Now,
come.
what there are some drugs which are other than these are which you can say stimulant of fetal hemoglobin chain or gamma chain, or they increase the maturation of RBCs. Can you tell me, Mithila, one or two drugs?
Yes, sir. For the RBC, good quality of RBC production and maturation, the new
Hmm.
drugs like luspatercept,
Luspatercept, you're right. There was
luspart-
another
and there is a sir,
drug with the name
mitapivat,
Metagross.
sotatercept, but that was
mitapivat.
given up. After that, they tried. Once luspatercept was accepted as the treatment for thalassemia, so the sotatercept trials were abundant after that. Okay, tell me.
Then there is a gene therapies also
No,
added.
what is the problem with luspatercept?
Sir, there is a hypertension and thromboembolic episode, sir.
No, why? See, this drug luspatercept is basically, see, it increases the transfusion interval.
Okay, sir.
In very few cases, it makes you transfusion free. Generally, not in all, in 50%, in 33% cases, the transfusion interval may increase by 50%. Bus, not a magic drug.
Yes,
But
sir.
it is very expensive. Each
Right.
25 milligram. How is it? How it is given? Subcutaneous injection
Subcutaneous.
every 3 weeks for as long as you want to give for the whole life. And each injection of 25 milligram, it is approved for adults. So it is given subcutaneously. So for a 50 kg patient, you need 2 vials. Each vial is 33,000 rupees. So
Okay.
it did not pick up that much. So the company reduced it by almost half the price of this drug. But still, it proves very expensive giving that spending that much amount of money every 3 weeks for the whole life. It is
Yes.
effective in some cases, not in all. Then you have other alternative methods of treatment that includes hydroxyurea. One should not
Yes.
forget
Immediate
hydroxyurea is
HbA.
a very good drug, especially for thal intermediates.
Yes, sir.
It is approved since 1996 for sickle cell
Thalassemia.
anemia. But for intermediates, it is approved drug. In some of the cases, especially in those who have XMN1 polymorphism or those who have a particular mutation of IVS11, this thalassemia means they may respond to
Hydroxyl.
hydroxyurea. Thal majors also. We have many cases who have
Yes.
responded to thalassemia majors who have responded to hydroxyurea. Then there are some trials of thalidomide also,
Yes.
but it is not an approved drug. It
Yes.
has got a lot of side effects. So many people, they don't use. Most of the people don't use. Everyone says that if one wants to give, it has to be given as a trial and under strict supervision. Okay.
Yes, sir.
Then there is a new drug which has come. Go and read about it today. Mitapivat. Did you
Yes,
read?
sir. Mitapivat. Yes, sir. Mitapivat generally used for pyruvate kinase deficiency.
Yes, pyruvate kinase disease. It has been used. Now it is approved for use in thalassemia. It was
Yes.
approved last December only, 25
Yes.
December. But it's a very expensive drug. This is the first oral treatment for thalassemia. Okay, read more about this drug. Then what else is the treatment
So gene
other
therapy.
than gene therapy? Before that,
There is
एकदम jump करोगे gene therapy पे.
hep
Before that,
hepcidin agonist and inducers are also
वो
there.
JAK2 and JAK3 वो नहीं.
हाँ, Jack.
और
Um,
bone marrow transplant.
yes, sir. Sorry, sir. Bone marrow transplant.
Bone marrow transplant we offer to all newly
Yes,
diagnosed
sir.
patients if they have a donor
Yes,
available,
sir.
because it is a cure for thalassemia. Whatever we have discussed till now is treatment of thalassemia.
Yes, sir.
What bone marrow transplant does is a cure for thalassemia. We call these thalassemia patients as ex-thalassemic after that, once there is a successful bone marrow transplant.
Okay.
Okay, for bone marrow transplant, you have to have a matched donor.
Yes, sir.
And then और क्या प्रॉब्लम है बोन मैरो ट्रांसप्लांट की? कॉस्ट.
Yes, sir.
Then there is donor availability is the main problem, because brother, sister, siblings only can be good donors where the success rate is very high, and the chances of a sibling being a donor are only 25%, and it costs around 15 lakhs or more. When there is a complication, the cost does not increase, it multiplies. So they have to be prepared for that. Then there is a term used in bone marrow transplant called MUD, matched unrelated donor. It's a very good it's a source of bone marrow for the patient, but the results are little less than the match sibling donor. Sibling donor is the best. Related donor is the best. Some people have tried haplotransplant. What is
Yes, sir.
haplo?
Sir, if it is whatever it is less than 12/12 match is called haplotransplant.
No,
Generally,
haplo is half match. भाई haplo. Haplo का मतलब ही half तो होगा ही ना. Half either mother or father. There will be for every thalassemic we have a haplotransplant donor available. But results are not that good. Only few centers in India have reported reasonably good results with haplo. In other centers, the results are not good. Okay.
yes, sir.
I think we have covered most of the thalassemia that you should know as postgraduate. Now, do you want to ask me anything?
No, sir.
Tell me. Anybody else wants to ask anything? Raj, your comments?
No, sir. Sir, I think everything, all the topics are covered.
The common
Yes, sir.
things that they should know, I think we have covered them.
Yes.
Day-to-day management, what the examiner is likely to ask, because more than that, they would hesitate to in asking you, because that will be a then hematological super specialty level questions. Then they will have. Okay, so good discussion. You have read. I know you have read thoroughly. Very good
Thank you, sir.
presentation and good discussion you had. Okay, good.
Okay, thank you, sir. Thank you for
Okay, bye
giving
bye
your
bye.
time,
No, it's all
even
right.
though you are on holiday. Thank you, sir.
No, it's all it's fine with me because I was sitting here only. I thought I'll join and
Because of you, it
okay.
was very wonderful discussion, sir. Thank you, sir.
Okay. Thank you. Bye bye.
Thank you,
Bye
sir.
bye.
Bye.
Bye. Bye.